Thank you for the invitation. First, I will say that I'm Melita from Indonesia. I work in National Brain Center as a neuroradiologist consultant. Today, I hope I can share some cases about the imaging in epilepsy. I thank you for the committee to invite me to allow me to speak here in the moment a very great Indonesian PARI, Indonesian Radiographers Community for the 65 birthday, I think, yeah, and the 9 of the CPD of the Asian. May I share screen? I hope this will be I hope it's divided can use for the others, for the radiographers, because here I speak maybe some cases, and maybe it's not and how to make it the cases well. We can diagnose it. Thank you. I start. The goals of the neuroimaging in seizure and epilepsy. First is the most important one is to identify the underlying structures of the malady. And the others is like predict the structural pathology, to detect dual or diffuse pathology, and also for the preoperative surgeon, to look at the function with respect to the lesion, and also for the post-operative to identify why it still have seizure after the operation, and also to provide alternative diagnosis to the seizure. Investigation of epileptic patient, we begin from the clinical and the EEG. So we call also clinical encephalography. So before we start imaging, first we must know what is the clinical and what the EEG finding. After that, we can make the neuroimaging with morphologic imaging like CT of MR, or the functional imaging like SPECT, PET of function MRI. This is a modality that we can use, start from the CT, and then MRI, and then also PET here. I start with computed tomography. In emergency case, we can use a CT scan with high resolution that cannot be allowed. So we can correctly detect hemorrhages, gross structural malformation, large tumor, and calcified lesion. And in refractory epilepsy, we can can use 58% to look at the lesion in CT versus the MRI 83%. And with CT, we can miss many small lesions, like include tumors, malformation, vascular malformation, sclerotic hippocampal, or malformation of the cortical development, FMCD. But this is still used. We can still use the CT if we cannot perform MR. R is contraindicated to use MR. And the main imaging for this epilepsy patient is MR. Why? Because it has higher sensitivity, better spatial resolution, and soft tissue contrast. Yeah, and also we can look at the multiple plane imaging. Yeah, and if we feel the epileptogenic lesion, MRI often add new and important data as a guideline, and should be done in epileptic surgery. Before epileptic surgery, we must done MRI. And with new advanced technique, we can look at 80% of the refractory focal seizure and 20% of single seizure in epilepsy in control. So we can attack again. And in research, 85% of epilepsy with normal MRI, we can find focal lesion after re-examination with MR. How about PET scan? PET scan is used in complex cases. So for surgical planning, yeah, we use here fluorodeoxyglucose, and we can look at the hypometabolism area at the interaxial scan. Also, if we use this PET, if clinical and EEG is not correlated with MRI, or we can say we cannot find the abnormal structure in MR. So also we can use in for patient with focal and drug-resistant epilepsy. Until now, Indonesia, we have not used PET scan for epilepsy. I hope National Brain Center will can give this can get this PET scan in the next year. I hope so. Yeah, we have prepared for that. And how about functional MRI? Functional MRI is a non-invasive and non-ionizing radiation technique, and to map the regional change in the brain metabolism and regional blood flow in the certain tasks. Yeah, the principle I think already know. We use VOLT here, and this is evaluation for the pre-surgical implant in intractable epilepsy. In 1998, ELI have make protocols for MRI. It's begin with T1, T2 weighted imaging with thin slice, 3D volume, it's or coronal or axial, flare, if standard imaging is normal or claiming a possible focal abnormality, the hippocampal volumetry and the T2 relaxometry, and we can use gadolinium if we find tumor vascular. But now, in 2017, the ELI made a commission for diagnostic have a new neuroimaging task. The formulated will be have new consensus. To answer the following question: first, who should have an MRI? And second is, what are the minimum requirement for MRI epilepsy protocol? And three is, how should magnetic correction and imaging be evaluated? And four is, how to optimize the lesion taxis. This is new in 2019, yeah? And the neuroimaging task from the ELI have new recommended harmonized neuroimaging of epilepsy structure sequence protocol, or we can say harness MRI. The main advantage of this harness is must be high contrast, must be second with isotropic voxel, and also can be obtained in 1.5 or 3 Tesla, and applicable to adult and children, and provide complete brain coverage, yeah, and no need for aperture-dependent slice annulation because we make it in 3D. And also imaging be reformatted and in the plane without loss of resolution. Yeah, and the greatly reduced vascular volume effect. This will be explained by Mr. Wahyu. I think this is not my competence to speak about that. Yeah, and provide improved signal to ratio and tissue contrast, and also can use GRAPPA asset sense with the multiple array heads coil. This is the recommended from the ELI, from the neuroimaging task force. This is the mandatory that you can see. Use T1 in 3D, yeah, to get the high resolution. Use T2 3D also. 3D flare. I mean, so can you use T2 in 2D, yeah, to look at the hippocampus usually at the perpendicular to the temporal lobe, and also we can use contrast or susceptibility weighted imaging or SVI. This is this is the protocol, the harness provide T1 3D, yes, in T1 tier, the flare 3D flare, also the 2D. This is the 2D. It's oblique or coronal oblique to the hippocampal, yeah, it's to the temporal lobe, so we can look the hippocampus very clearly here. And in 2017, also Eli give the new classification epilepsy. So we can choose the type of seizure, the type of epilepsy, then the etiology, some etiologies. This is the new one. So I start in NBC. We have until now epilepsy protocol. Usually we use routine. First, we use routine MRI. Yeah, it includes axial WI, T2, and SY, and then coronal oblique for the specific epilepsy, temporal epilepsy. Oh yeah, before we made this protocol, we always see the clinical finding first on the EEG report. And from that, I can decide it. Can you use the T2 coronal, or we must use the 3D T1ER or the 3D flare or the 3D DIR, a double inversion recovery. Usually, we use the DIR in epilepsy outside the temporal lobe. Yeah, like the EEG finding. We can in the EEG finding define the abnormality in frontal or in parietal or occipital. And you use volumetric hippocampal is in exception also in a rare case, yeah, if the hippocampus is between the right and the left side is not clear, so we must follow the volumetry, and we give contrast if we find tumor or vascular abnormality. Yeah, okay. I begin with the epilepsy in two parts, in the temporal lobe and the extratemporal lobe. Epidemiology, temporal lobe epilepsy is 60% of the whole epilepsy, and the rest is the other location like frontal, occipital, parietal, or multilobular. Okay, I begin with temporal lobe epilepsy. Abnormality in MRI of temporal lobe epilepsy usually is a atrophy of the temporal lobe, usually in mesial and the lateral. It can be also unilateral or bilateral. And other structure cause can be of tumor. We can find malformation, we can infection, we can find gliosis or neuron loss, post-trauma or post-infection or post-stroke. And also, it can be normal if the epilepsy is genetic, so we cannot find any lesion. The key point of the MRI in temporal epilepsy is the coronal MRI slice, yeah, to the axis of the hippocampus. Now, at this time, we can use 3D. So I can directly make axial line with the coronal oblique to the hippocampus, to the temporal lobe. And in MRI, we can see the hippocampal sclerosis also. It's atrophy or loss of internal structure of abdominal shape. And also we can see the increase the signal in the T2. If we can find bilateral or mild unilateral lesion, we must use volumetric analysis. And MRS you only use if I use the rare MRIs because it's very difficult to have a good result, and it's very and many artifacts. Yeah. Okay, this is, I want to see how the technique, it's the coronal oblique. Yeah, this is the temporal lobe. So we make it coronal oblique perpendicular to the temporal lobe. This is the result after we make it, and we can see this is the hippocampal. And I want to see why you must use 3D tier. This is the T1 spin echo, normal spin echo, and this is the 3-1-ER or irreversible recovery. We can look at the cortical. The cortex is very different with the white matter because the epilepsy, we must look at the cortical side. For the hippocampal malformation analysis, we must looking for the atrophy of the hippocampal, either hyperintensignal on T2 or flare. We can look at the loss of internal structure. We can look also the asymmetry of the temporal horn of the lateral ventricles. We can see also abnormal shape around or pyramidal of the hippocampal, and also abnormal rotation or vertical oriented. Yeah, and also we can find the atrophy whole the lobe of the temporal, not all just the hippocampal. Usually, we find sclerosis in the mesial temporal, where we can find the hippocampal is small or atrophy. This is the specific finding. We can see the increased signal intensity in T2 and with loss of internal structure, or we can find also abnormal shape and rotation of the hippocampal formation. This is the case with the small and brighter hippocampus in the left side. It is the right side, between the right side. And in T1ER reverse recovery, we can look at the loss of internal structure of the hippocampal. And this is, I will show you the abnormal rotation and shape, like this one. This is the left side. It's turned to the medial side. It's very clear from the beginning, yeah, here. And we also can find here in T1, T2 or flare, but we don't find any hyperintension in flare or T2, only just abnormal shape and the rotation. Also, tumor of vascular malformation like cavernous angioma, we can find in temporal lobe. This is the case in brain center. We can look at this is a popcorn-like appearance in the hippocampus, near the hippocampus on the left side. And also we can see at the SWI, SWI, hypointense lesion around the lesion. It means there is a bleeding, a post-bleeding in that area. I want to show how we make a hippocampal volumetry. Usually I use manually. So I make it round every single of slices, and then we counted, we calculated. This is very wasting time, but we must do that. Usually one of my doctor in NBC always ask for that, so it's take much time to do it. Yeah, it's very complicated because you must make a draw it one by one like this one, and then you calculate it. But now there is a T2 relaxometry. This is a software that we can calculate the hippocampal's volume without manually, but until now I don't have it, so I still use it manually. And in MRS, I have told you before, it can be used, but it's very difficult because of many artifacts we'll find, because hippocampus is near the ventricle horn, yeah, the temporal horn of the ventricle lateral here. So will be many artifacts we'll find. How about the extra hippocampal? Yeah, we can see here the abnormality usually atrophy of the ipsilateral of the amygdala, the temporal neocortex, the temporal lobe white matter, the fornix, the mammary body, the insular, the thalamus, or the basal frontal cortex. And also we can find the contralateral atrophy of the hippocampals, and also the dilatation or ipsilateral of contralateral of temporal horn. Usually often false lateralizing finding, yeah, because usually dilatation of the temporal horn more severe on the side of the contralateral of the sclerotic. And also we can find atrophy, diffuse atrophy of the hemisphere or ipsilateral, but this is very rare. We can find the extratemporal lobe, usually tumor, like this is a meningioma. We can look at the post-contrast lesion. We can look at the bright diffuse contrast enhancement in the anterior of the temporal lobe. It's big. And in the T2, and we can see it's iso-intense with the cortex. And in the flare, we can see the edema surround the lesion. And in vascular malformation, like this one, also we can find in the area of hippocampal region here. This is a with hemosiderin rim. This is a cavernous angioma. And in other lesion that can be found is heteropia and the focal cortical dysplasia. This I want to see, this is the case with subcortical medial right temporal lobe. We can see here heterotropia with multiple patchy area of the cortical on the cortical cortex of the lobe, cortical lobe, yeah, of the temporal lobe. We can see here clearly in the sagittal, in the coronal and axial, and also in flare. And well, how about focal cortical dysplasia? Usually it's very difficult if sometimes it's subtle and also it can be negative. Yeah, and usually you use 3D flare or double infection recovery to find that. And often in the abnormalities in the bottom or the deep sulcus of the temporal lobe. Yeah, and also another finding is blurred interface between gray and only white matter. This is a very difficult to find. This is the case of the FCD. In the T2, we seen this is maybe this is the abnormality. We can see the hyperintention in the T2, and the flare we can look at more clearly. Yeah, in the after contrast, we don't see any enhancement after contrast, and the coronal in the coronal oblique, we can see that is hypointense in the gyrus of the temporal lobe, that we can see more clearly than in without protocol of the epilepsy. This is with protocol epilepsy, we can see it more clear. And this some case with HEP-CD and hippocampal sclerosis. We can see here hyperintense lesion in the T2 and the flare, and also abnormality in the left hippocampal. This will you see here very bright on T2 and on the flare. How about PET? This is I took from a journal. If there is a hypometabolism in the right hippocampal, you will use in subtle cases, or we cannot find abnormality in the MR. This is case with bilateral hypometabolism of hippocampal. We see here both, yeah. In MRI, we cannot find abnormality. We can looks like normal, yeah. Okay, but in the PET, we can find abnormality. And this is multimodality imaging with MR, with the PET, and they put it together, fusion in the SysCom, so we can see where is the located of the abnormality. Because usually the PET is not specific, but very sensitive. So we put it together with the SysCom, so we can find the exactly location of the abnormality. Also with this FCD, non-specific, in MRI, we suggest, is it abnormality? I don't think so. But in PET, we can see hypometabolism in the anterior temporal lobe. This is fine, yeah. That's why we need a PET scan for the subtle abnormality. And also, if we need surgery, we must do PET. Until now, we have one center who use PET in epilepsy, and usually they use for the surgical patient, yeah, but not in my hospital. How about epilepsy, the extratemporal? So we can find in the extratemporal, usually the main structure pathology, the MCD, tumor or tumor-like lesion, vascular malformation, post-traumatic lesion, or infection. I want to look for the MCD first. It can be abnormal cell population, abnormal neuronal migration, abnormal cortical organization. Okay, we start with abnormal proliferation. Usually it's still a child, yeah, a baby child. And we can see here no gyrus. We cannot see no gyrus. Here all plain gyrus, yeah. And this is the many or minimal sulcus, yeah. We don't see it very clear. And also the second one is tuberous sclerosis. The specific finding will be C nodular in the periventricle, and also abnormal cortical dysplasia in the cortex, like in frontal, in the occipital area, or in the parietal. Also, we can find it. And also we can find here FCD only in frontal lobe. We see here bright on flare. This is with deer, yeah, this is deer. We can see more clearly. And this is the T1. We can see the hypointense in the area of the focal cortical dysplasia. This is more cases with FCD with transmantle sign. So you can see it's bright side from the cortical to the area in the, usually in the periventricle area, like this one. Yeah, this is deer. That's why we need double inversion recovery for looking that's abnormality. Other abnormality for the proliferation, abnormal separation, this is a tumor. This is a dysembryoplastic neuroepithelial tumor. In T2 only seen hyperintense lesion. In T1 hypo, and also in flare, it's very clear the in deer, not only flare, there is a double infection, a deer flare. We can see very bright abnormality here. How about the neural abnormal in neuronal migration? We look at it, band heteropia. Why can we, our double cortex? It means we find cortical in the area of white matter. It's very clear if we make it in flare or in T21. So we can usually on the cortical, gray matter is in the cortical area. But here in this case, we can find the cortical intensity in the gray matter intensity in the white matter. This means double cortex. Sometimes we can see also with CT, but if it's the abnormality is very clear like that, is it subtle, we cannot use CT here. The third one is abnormal in the cortical organization. Usually we can find the polymicrogyria. Why it's polymicrogyria? We can find here the gyrus is very small and it's multiple. This is with T1 inversion recovery. We can look at the very clear the abnormality. This is the normal side in the temporal, and the frontal area. We can see the abnormality here. Also with the flare or the T2. But the T2 is not very clear, I think. Yeah, more clear in the T1 inversion recovery. And other case, you can see also it's very clear in the insular side, yeah, multiple polymicrogyria. With the deer double inversion, we can see more clearly. The other abnormal cortical organization is the schizencephaly. With this case, I show with open lip. It can be closed lip, it can be unilateral or bilateral. In this case, is a unilateral open lip. We can find there is a connection between the ventricle and the subarachnoid area. In the subarachnoid area, we can see it clear here in the double inversion or in T1 ER also. Now, this is the case of the closed lip of the schizencephaly. We can see there is a band, but there is no contact area directly to the ventricle. Another abnormality is tumor and tumor-like. I will show you some tumors that can be in epilepsy patient. First, the NET, ganglioma, oligodendroglioma, or low-grade glioma, usually astrocytoma grade 2. Like here, oligodendroma lesion, we can see like hyperintense in T2, hypointense in T1, and in PET scan, the abnormality is very clear. How about the vascular malformation? Here is the case of cavernous angioma in the cortical area. Is you can see in the gradient echo hypointense, also in T2, but in T1 you see hyper. This is mean there is a subacute subacute hemorrhagic in the lesion. That's why we can see it hyperintense in the T1 lesion. Now, in the post-traumatic lesion, usually we can find gliosis in the frontal area. You can see here in the frontal area, and also in this in the posterior in occipital lobe, we can also look at for the gliosis area. Okay, and last in infection, I show you patient with cysticercosis for infection become calcified. Also in CT, we can see the neurocysticercosis clearly, and with a new lesion with scolex inside. And in MRI, we can see the calcification also like this one. Okay, I think I finished my presentation. Thank you very much for your attention. I give it back to the moderator, please.